Everybody can see it?
Yes, ma'am.
Perfect. Well, everyone, welcome to our 42nd virtual shadowing session. Tonight, we're going to be covering internal medicine pediatrics with Dr. Grossman. And this is our fantastic team. It's composed of myself, Reagan, Shayan, Taylor, Elena, Rachel, Ani, Miriam, and Rohit. And then, of course, our 4 physician coordinators, Dr. Fowler, Dr. Marchetti, who is here tonight, yay, Dr. Salazar, and Dr. Reno. And then our upcoming sessions. So super excited for this week. We have another session on Thursday. It's our rescheduled cardiology session. And then next Tuesday, we'll have a specialty spotlight on orthopedic surgery with Dr. Sloan. And you can catch all of those on Zoom or YouTube Live at 7 p.m. Central Time. And then if you have any questions, we will have 2 Q&A portions in our session. And so just put your questions in the chat and we will try to get to them during those times. And Dr. Feller, I think you wanted to say something.
Just want to welcome you all back, all 630 of you. It's so good to have you here. As of this afternoon, we've already crossed 48,000 of you in 28 nations and 951 universities around the world that have joined virtual shadowing. So we're so glad to have you. This is our 42nd session. We now have about 75 hours of material online, and we've had almost 210,000 viewings of these sessions. So clearly there's a need. And if you want us to keep doing this, let us know. We're kind of going to think it through come this summertime, and at which time we'll have probably 70, 75 sessions on board. And so if you want us to keep coming back, we'll be here. I think we've had some extraordinary setup. Look at the chat. That's so sweet things. But anyway, we know that this means a lot to you because it means a lot to us. And we're looking forward to continue this participation. Now, we're having an issue with the email server. And so Reagan or Rachel, do you want to speak up real quickly about the email?
Sure. So we are trying to figure out the best way to get in contact with everybody. So we're trying a few different email servers out and we're kind of hitting the wall. So if y'all could check your email inboxes or your spam or your promotions or your junk, we are sending out emails this week through a no reply at virtualshadowing.com. So if you could be on the lookout for that. And then also this week's email is a little long. And so you might not be able to see the assessment information unless you click view in browser. And so that might help you be able to see the whole email this week. Dr. Fowler, anything else?
Well, I think that's all. We just want to, again, thank you for coming. We thoroughly enjoy these sessions. These are very eye-opening sessions for us because for those of you who've been to many of these sessions, we have covered a broad spectrum of the practice of medicine. So we know this is a very important time for all of you, and we want to continue to bring you stuff that we think will be helpful. I'm on the admissions committee at the UT Southwestern, and I'm very much looking this year to see how the admissions committee is going to treat virtual shadowing hours. It's going to become so normal because thousands of people have been here. So I'm hoping that from the standpoint of admissions committee that virtual shadowing hours will be counted as shadowing hours. So we'll keep our fingers crossed on that. Delighted to have you here. And Rachel, I think we have a wonderful guest tonight. Would you please introduce Jeremy?
All right, Dr. Grossman, thank you so much for joining with us tonight. And I will give it to you and you can take it away.
Thank you so much. This is a wonderful organization. I didn't realize the whole backstory behind it and how much work you guys have done. It sounds really amazing. Thank you so much for having me. I really appreciate it. Thank you all for tuning in. There's so many of you in the chat. It looks like amazing. So my name is Jeremy Grossman. I'm a resident physician now. So almost finished along my training path. Of course, the field of medicine is a lifelong training, of course. Originally, I'm from California, in Orange County. So I saw a few Orange County people in the chat there. So welcome, represent. And I grew up there for most of my life. And I went to high school there, and I actually went to college down there as well at the University of California, Irvine. I got my bachelor's in biology, and I also got a bachelor's in psychology while I was there. Took a year off after. I did some tutoring work for high school students. I did some volunteering, and that ultimately led to me going to medical school in Israel at the Sackler School of Medicine, which is kind of a joint commissioned medical school between the state of New York and the state of Israel that essentially trains physicians in Israel for the first 2 to 3 years. And then the last year, you do some training in the States and ultimately come back for residency in New York. So last year was my first year in the residency program. The program I'm in is internal medicine and pediatrics. So for the most part, most residencies have a single degree. Internal medicine, pediatrics, general surgery, emergency medicine, like Dr. Fowler.
Jeremy, 2 quick questions. Fowler
Yep.
here. What is an anteater? We're saying the fellow anteater. Has that got something to do with you?
Yeah, so the University of California, Irvine anteaters are the mascot. So it was kind of a joke when the university was created, I believe in the 60s, and they were a bunch of college jokesters. They let the students pick. Bad decision because it led to an anteater being chosen. And of course, you have UC Santa Cruz in the north, which is the banana slugs. So I don't know which one you would pick. I guess I'm an anteater for life. If we say a weird thing, we go zot zot, which I guess is the sound an anteater makes. And this kind of looks like an anteater to some degree.
Somebody just put zot zot in chat. So there you go.
Did they?
All right. All right. Rock and roll.
You rock and roll. That's right. Thanks for covering that. So right now I'm in the state of New York at Stony Brook University Hospital. I'm working as a resident physician. I'm a second year now, so that means you're a senior resident. In your first year, you're an intern. So again, most residencies are kind of a single residency, and obviously I had a really tough decision, and I really couldn't choose between the two. I actually had thought about doing family medicine, which actually has been around roughly the same amount of time as internal medicine pediatrics, but family medicine, I believe, is a more popularly known career choice in medicine. It's very outpatient driven. You can go into inpatient tracks of medicine. You can work in certain ER departments. But ultimately, throughout my kind of medical career, especially in the 4th year, I felt like I really wanted to do inpatient medicine. I liked the acuity. I liked how close you were to the patients, following their every value and seeing how they were doing. And ultimately that led to me choosing to do the inpatient kind of practice of family medicine, which is, I believe, is internal medicine pediatrics. Two of the big differences are in internal medicine pediatrics, you don't have OB-GYN training like you do in family medicine. And the other difference is it's primarily inpatient training. With a very strong pediatric education, which I believe is limited to somewhere between 6 to 8 months total, if I'm not mistaken, in family medicine versus a full 2 years in internal medicine and pediatrics. I made these slides, so I guess I'll follow them to some degree. I live in Long Island, New York, in a town called Patchogue. Very fun little spot. This is my dog, Zeus. He's sitting next to me on the bed right now. So if you hear a bark or a growl, it's him, because I live in an apartment complex, so people are walking by, so just ignore it. I might look over at him a few times too, so that's not like there's nobody there, just my dog. I play guitar. I play about 5 musical instruments, but that's really the only one that's really persistent and I really enjoy. And I recently decided that I liked, I guess, collecting watches. So I've been, having some fun with watches, I guess. I guess that's pretty much covers this slide. I know there's Q&A.
Jeremy, if you were to pick up your guitar, you'd be the first one on virtual shadowing out of 42 lectures to do that. and I don't think we would mind if you did a minute riff or two for us. We've already gotten a bunch of Zeus reveals, meaning that they would.
They want to see Zeus, huh? All right, so we'll pull up Zeus later. My bed isn't made though, so I don't know if I should show you, but maybe I'll show you at the end.
All right, keep rolling.
And I'll probably won't be the first to play my guitar because I don't have one here, and two, I'm way too shy to play it for 653 people. So, but thank you for trying to embarrass me, Dr. Feller. I do appreciate that. So I said already where I grew up. Of note, I'm a type 1 diabetic, so I've kind of been in and out of the medical arena my entire life. And spent a lot of time at this diabetes camp called Camp Conrad, which is in California in Big Bear, if some of you have heard of it. And spent 10 years there, started out as a camper and worked my way up to a counselor and as a medical, staff member taking care of kiddos. And that kind of just fed into my passion for medicine and really treating and taking care of others. I said where I went to college. I told you where I went to medical school. So a bit about my residency program. It's 4 years total. Family med is 3 years. So I'm stuck here for 4 years. I'm almost 2 years done. The last year of COVID made this last year go by really slowly. I'm sure Dr. Fowler felt it in the ER as well. But almost halfway done, got 2 more to go. And basically by now I've been exposed to most of the rotations that I'm seeing. So as a Medpeds physician, you can really see anything. Like one day I'll be working on the newborn nursery. Right now I'm actually working on the NICU this month, the Neonatal ICU. I'm catching babies, resuscitating them, treating their infections, intubating them, or rather trying to. It's really tough. And then another day I might be in the adult ICU or maybe in the cardiac intensive care unit. Sometimes I work in the ED like Dr. Fowler and the Peds ED. So you move all around the hospital, and there's a lot of specialties that do that, but we're definitely more primarily trained in general patient care and ICU care across the hospital. So I really enjoy that diversity. But going into this field, and I would think emergency medicine as well, family medicine, a lot of the surgical specialties where you're working with adults and kids, there is a huge learning curve, and you'll feel behind your peers because everyone's dealing with one population, whether it be adults, kids, surgical patients. But for me, I really had a tough time because I was behind all of my peers. I'm working with pediatric residents and I'm working with internal medicine residents, and they're all progressing forward, and I'm still struggling with two different specialties that sometimes are opposing and don't make sense and crisscross and are really all over the place. But ultimately I survived, and I'm sure all of you will too. But again, something to think about when you're going into residency is what your day-to-day life is going to be, what type of patients you're going to see, what type of setting you're going to be in. Are you going to be in a hospital? Are you going to be in the outpatient setting? You got to think about all these things before you pick a specialty, because ultimately, at the end of the day, you are practicing medicine and you are going to be using your head. And there's really a lot of similarities between all the fields in terms of kind of what you're dealing with. But it's those differences between the fields, in my opinion, that really have to set that field apart if it's something that you want to go into. I knew I didn't want to cut. I wasn't, big with my hands. I didn't want to be a part of those surgical personalities in the operating room. I didn't want to be scrubbed up and couldn't do anything for 6 hours or stuck in the hospital for forever. So these are just some things that I was thinking about. But on a positive note, things I was thinking about, I loved inpatient care. I loved working with kids. I loved babies. I loved adults. I loved grannies and grandpas, the whole spectrum. So you really got to think about what you want to do at the end of the day, and what you don't want to do. At least more importantly, from what I've learned, is what I don't want to do. And I'm lucky that I've been exposed to so many different fields, and it really helps me make a decision at the end of the day. So I would assume that most of the participants today are pre-health, meaning they are college students or high school students.
That's correct.
So I would say that from my experience, I was interested in family medicine. I knew a little bit about, the medical field from that perspective. And so I decided to do my shadowing or my getting a lot of my kind of pre-health education from a family doctor and reading up from the perspective of a family physician. Like AFP.org is a really great site. So I, encourage any of you who are going to pursue shadowing, if that's even an option. You guys at Virtual Shadowing probably know better than me that that's something tough to do right now. So I think what you guys all are doing by being on this this virtual shadowing website and being a part of this community, that's awesome. But when that chance does come for you to be able to shadow in person, I really encourage you to go into a field that you're interested in and not just something that works out. I was under the impression when I was in college, and again, please cut me off if I'm like going in a certain direction. I'm just going to blabber on. I was under the impression that I had to go into an organized program, and I worked at this hospital that had this instituted volunteer program. And really what we were doing was just kind of aid work, handing towels over, bringing cups of water, and it really wasn't fulfilling. And yeah, I got my hours, but I didn't enjoy what I was doing and I didn't learn anything. So I actually quit that and I said, I can't do this anymore. I want to spend my life and my time right now doing something that's going to improve my success in the future and expose me to a field that I'm potentially going to, give 10, 15, potentially my whole life to, right? So I went around and I looked online and I said, doctors near me, whatever, it doesn't matter who, family doctors near me. I emailed 10, one responded, said, come on Sunday, you can shadow me. And it was so pure and so whole, and I loved it, had a great time. He was an amazing teacher. I got a great exposure to medicine. I don't know if he ever was mad at me for not going into family med. I went into Medpeds, so it's similar. But it was a great time. So I definitely encourage you guys to all look into that as an option for shadowing. Okay, I think I talked enough. Do I have more slides? I forgot.
Yes.
Why medicine? All right, so I guess I did touch on this a little bit too. These are all great stock photos I picked from Google, so just enjoy the stock photos. There's a little, on that photo there's a little test kit. So as I mentioned, I'm a type 1 diabetic. And I've been dealing with it, or living with it rather, for 15 or 16 years. It's really a huge part of me. And I actually had a big concern. I'm sure a lot of you, or at least a good portion of you, have some sort of medical condition that you're dealing with. And maybe that you wanted to, I lost my train of thought, but maybe you have, how do I put this? You've had exposure to some sort of disease that kind of got you interested in a field of medicine. And I say, hold on to that and kind of go with it and run with it and see where it takes you in terms of your learning and your pre-health learning. I'm sick of diabetes. I deal with it all the time in adult land and kid land, and it's a big part of my job, but it's a big part of my life too. So it actually is a strength for me in terms of patient care. So that's kind of a big reason that got me into medicine. I kind of almost felt like, I think I was 15 or 16, and I felt like, okay, this is all I really know. Maybe I should just go into this field. And really, I grew into the field and it became a part of me. But on that note, I would never want you to just go into it because you think it's a good field to go into. You should go into it because you truly want to go into it. You're dedicating so many years of your life into this field, so many. You have to love what you're doing. Grey's Anatomy and Scrubs. I used to love Scrubs. I used to think that was the doctor life. It's such a small part of your life. That whole drama and like, oh yes, hey, I'm the doctor. Hey, how you doing? Da, da, da. It's such a small part of your life, and that becomes such a minute part of your life that if that's why you're going into medicine, it shouldn't be why you're going into medicine. You should go into medicine because you love taking care of people. You really enjoy the pathology, the physiology. You've had exposure to the field and you just feel right doing it. Maybe you come from a family in healthcare. Maybe you want to go into it for that reason. Whatever the reason, just make sure it feels right. Because at the end of the day, that's what you're going to be doing. That's what your life is going to be. I was just telling the team at Virtual Shadowing before we let you guys all into the Zoom chat. I just got off at 7:30 from my shift. I've been up since 5 a.m. I'm so tired. And I'm on an ICU shift right now in the neonatal ICU. I normally drink a lot of coffee during the day to stay awake, but I'm on like energy drinks now. I'm so tired, but I love what I'm doing. I absolutely love what I'm doing. And I wouldn't trade it for the world. I'm so tired. As soon as this is over, I'm going to pass out and just sleep for 6 hours straight.
Hey, Jeremy, what's the hardest thing, that kind of case that you saw today?
we have this kid with a case. Thank you for the question, Dr. Fowler. Thank you for keeping me on track. I'm a babbler.
No, I mean, you've just come off a tough shift. You're still wired, which is wonderful. I drink 10 cups of coffee a day. I bet you can't drink as much coffee as I do. But what's the hardest thing you saw today?
So I saw this kid. He's a premature kid. So normal kids are born, rather normal term kids are born between the ages of 37 weeks in the mommy's belly to about 42 weeks. This kid wasn't too young. We see kids sometimes as young as 24 weeks and maybe even a little bit younger, and can take a lot of them to term and you know, they can grow up to be healthy kids. This kid was 33 weeks, so he was well beyond an age that modern neonatal medicine can take care of a patient. And he was doing fine. We were feeding him. He was on a little bit of IV fluids to help him out because he wasn't feeding well. Fine, that's pretty normal. And then yesterday morning, the nurse calls me over and says, "Can you take a look at this diaper?" I said, "Sure, I'll take a look at a diaper." By the way, if you want to go into neonatal medicine, you got to be okay with looking at diapers, okay? Another thing, is this what you want to be doing? The diaper had a huge stool, a wet stool that was red. And the one thing your mind goes to as a doctor when you're looking at some sort of tissue or fluid that's red is blood. And that's scary. Nobody should be pooping blood. So in any preterm infant, you're worried about an infection of the gut that can lead to necrotic tissue, dying tissue in the gut. And that gut, if that's not taken care of, can die and be gone for forever. And that person might need to have a colostomy bag for the rest of their life. So that's later on. But it's very serious. You really have to take this very seriously. Whenever any kid you suspect has this sort of dying gut tissue infection, necrotizing enterocoleitis is the fancy term. So immediately what we did was we did an x-ray, okay? In the x-ray, we're looking for air in the belly, okay? And air along the GI tract, because that's a clue that there's some air seeping from somewhere because that tissue died, popped open, and the air can leak through. So an x-ray is a really quick way to see if there's something really bad going on in the gut. And we didn't see anything, which was good at first. We also did some labs, and the labs were looking at his hemoglobin and hematocrit, which some of you may know by now, taking some biology related courses, is related to your red blood cells, and related to really the capacity of your blood to carry oxygen to your tissues. So his was okay. Everything was really okay at first, but then slowly and slowly throughout the day, he was having ABDs, apneas, bradycardia, and desaturations. What does that mean? He was breathing slow and low. He was having low heart rate, and he was desaturating. So his oxygen levels were going down. And this is all very consistent with, it can be consistent with rather, an infection, anemia, so low blood counts, and a lot of different other things. So those are the things that are on our mind. We have to think about all these things when each of these symptoms come up. So more and more these apnea, bradycardia, desaturation events started to happen, and we said this kid might have an infection. Now with this gut infection, we're going to have to do x-rays every 6 hours. We want blood tests every 6 hours. We want to get cultures of his blood, and we need to give antibiotics right now because we think this kid has an infection. We got to start helping this kid out. And more importantly, because he was desaturating, he went as low as 40% when I was in the room. 40%, that's very low. You want your blood oxygen to be like in the 90s to 100s. We were like, okay, you know what? Even though this kid just goes up and it comes right back up, he's headed to a bad spot because the frequency of his ABDs keep happening. We're going to intubate him. So as the resident, I tried to intubate 3 times and I didn't get it. And I've never gotten the neonatal intubation, and that's okay because residency is all about learning. And I'm going to get the next one. Okay. You watch and see, I will get it. And of course, my fellow came by, did it in 1 second, said, okay, I'm going to go stabilize him. I have to go put in some orders. I said, okay. So the kid is now ventilated. He's on antibiotic therapy. And today His x-ray showed some air around his liver. His gut is distended. You can see the loops of his colon on the x-ray image. You can see fluid levels and pockets due to poor movement of the gut. So this baby's sick. So we consulted infectious disease, and more importantly, we consulted general surgery, who's not doing anything right now, but they're getting ready to go in there, open them up potentially, and remove that necrotic tissue, which is a source of infection, which is seeping into the baby's blood, which now has been positive for blood cultures. So it's a good thing we started him on antibiotics. It's a good thing we have him on a ventilator, helping him breathe while he's going through this really stressful period. And it's a good thing we're watching him every 6 hours, because clinical conditions can change like that. And the ICU nurses are fantastic. They got their eyes on maximum 2 patients at any time. So they're just going back and forth between 2 patients, keeping their eyes on them. And they're really our eyes in the sky. If anything happens, they let us know, and we're right there. Because really, as doctors, we're really behind the scenes, kind of looking at everything as a whole and trying to manage everyone as far as possible, as far as our eye can see. But really, when it comes to little details and little things we need to pick up, we rely on the nurses for that. So nursing is an amazing career. One is not above the other. They're both different in their own ways, and they're both equally important to patient care.
So Jeremy, this weekend I worked with a nurse that I've worked with intermittently in the ER at Parkland for 15 years. And she told me the story. I realized she was gone for a long time from Parkland. I'd kind of forgotten. And she told me that on the last shift she had worked at Parkland, she delivered her 23-week, this is the nurse, her own 23-week baby at the hospital precipitously as a 1-pounder. The kid spent 140 days in the hospital.
Mm-hmm.
And then I said, so, kind of tentatively, as you can imagine, so how is she now? And she showed me this picture of her as a 13-year-old pole vaulting 13 feet, setting the record for her age group. And I just almost cried right in front of her, Joe.
That's amazing.
Oh, it was amazing. The magic does work.
It really does work. Medicine has gotten to such an amazing point that I'm astonished practicing what I'm practicing every day. It's really amazing. I mean, neonatal medicine in itself, and again, this is just a rotation I'm on. I'm not a neonatologist, but I'm just amazed at the medicine that's practiced and the people behind that medicine, who can kind of endure these emotions that they're experiencing every day, dealing with these newborn infants who can be so sick and so ill, and dealing with these newborn parents who only kind of wish that they could have this kind of wonderful, beautiful experience of having a newborn, but rather their kiddo is locked up, especially in COVID times, away from them, sick, and they don't know what's going on second to second, and they're hoping that we call them and update them as frequently as possible. And sometimes that's not really possible because we're so busy in and of ourselves.
So Jeremy, you're up close and personal with some of the hardest medicine there is to practice. I've said for years that neonatal intensive care is probably one of the hardest fields of medicine to practice because the patients are tiny, getting IVs, getting airways, and so forth. How in God's name do you handle this thing about having to make such difficult decisions on tiny little babies?
I mean, that's an amazing question. And again, I want to stress that I'm not a neonatologist. I've done in total 2.5 months of neonatal care. I had an interest in it as a medical student, so I did a month of it. I did a month intern year, and I'm now 2 weeks into my kind of third exposure to it. But how these people do it, I think what's really important is beyond managing your emotions, and beyond managing parents' emotions and family emotions at the bedside, is learning through repetition and learning through experience. I can't say, and I can kind of extend that to all the other fields and rotations that I've been in during my residency. It's really touching as many patients as you can. And I say that in such a way that physical exam, seeing them, understanding their story, what led them from the second they experienced their symptoms to the second that happened right now, knowing what's wrong, what's right, what's okay, what's a little off, knowing all of these things it really just comes down to experience and knowing what it's, you know, in neonatal medicine, it's so much kind of touch and feel and just kind of feeling what's right. That's kind of the vibe that I've gotten from the attendings that I've worked with, where, by the way, they're all fantastic. They practice evidence-based medicine, which is extremely important, but they also combine it with their experience of what they've seen. And that experience drives not only their caution, but their passion and their drive to do what's best for the patient. Working on these little babies, I mean, I put in maybe 2 IVs on babies, and a nurse was holding my hand the entire time so I could get the credit for it. I mean, it takes such dexterity and such skill to not only find the vein, but get that small needle and catheter in there. Again, experience is huge, and it goes into any field. And I'm just going to relay that kind of back to what I said earlier. Please go, you know, when you're looking into shadowing opportunities, do it in something that you're interested in, get that experience, because, you know, it might not be what you go into later, but at least you'll have a passion to learn in that moment, and maybe you can apply that to whatever you do go into later on. Hope that answered your question, Dr.
No, that's wonderful, Jeremy. I over the many years with the hundreds of nurses I've worked with, for example, who might have been struggling with how to get an IV in an adult, I would say, you know, if you get an opportunity, go work in the neonatal ICU, because if you survive there and can get these IVs into things that look like whiskers, you can come down, you can come back to the adult ER and do just fine. Hey, look, I follow all the COVID numbers. We have a regional report here that's really quite nice. And you know, they talk about not seeing COVID in pediatrics, but really to the contrary, as much as 5% of the pediatric inpatients were COVIDs that we were seeing here. Did you see much COVID?
That's an interesting statistic. I would imagine that number to be much higher. I don't have that number in front of me. I'm actually working on a study right now that looked at the decrease in admissions related to asthma during the peak times of COVID, because of mask wearing, because of social isolation. But that's a separate story for another time. I think in a hospital setting, and I'm not sure, Dr. Fowler, do you work with pediatric patients in your ER? Are you exposed to that?
Only if they happen to end up in the ER. I had a failure to thrive in a 7-day-old a few months ago, and the mother only spoke Mandarin Chinese, and that was exciting. Wow. And we had to use Google Translator to try to get this kid stabilized to be able to get him over to the pediatric ICU. But at Parkland, it's really an adult hospital. We have Children's Hospital next door, literally. And so only if they end up, you know, by serendipity.
I see.
This is great stuff. Keep going. I'm sorry to keep interrupting you, but
no, I like to make it a discussion. As much as I like to hear myself talk, I really actually don't. But being in this field has made me become more of a talker, so I guess that's a positive. So I mean, in pediatric patients, I think we all know, at least from all the headlines and news headlines, is kids are just not as affected by it. But I don't think that that's a representation of kids not getting it. I think that's just kids not being symptomatic from it. I can't tell you how many patients on the pediatric ward, on the general floor of kids that get admitted to the hospital, how many kids just had COVID, but they were there for an entirely other reason, which really kind of just goes to show you how kids are really can just generally not be affected by this condition. Now, there is this condition called MIS-C, which is a very severe kind of case of COVID inflammatory response in kids that can be very severe, where a patient can end up sometimes in the ICU. And that's kind of a separate story and more related to kind of inflammatory surge of cytokines. But for the vast majority of pediatric patients I've seen, they've kind of tested COVID positive, just because we test all of our patients that are admitted to the hospital for isolation. If I'm admitting a kid with a UTI and they're going into another room with a kid with pneumonia, if that kid has a UTI on top of COVID, now I'm going to be exposing that kiddo with pneumonia, with a bacterial pneumonia, to a case of viral COVID. So now they might have 2 infections and they might have really bad respiratory problems. So it's important for isolation, but it also just brings up a lot of asymptomatic COVID patients. Yeah, hope that answers the question.
Keep rolling. You're doing a great job. Take all the time you want. Questions are pouring into chat, so we've already got dozens to ask you. So keep rolling.
Please, yeah, I'd love to answer questions. I think that's probably the best way to go. I'm here to help people, not just talk about whatever I want to talk about. Do we have a question?
No. We're just, please keep going. What's the National Medpeds Residents Association? What is that?
Okay, so NAMPRA, yeah, is the National Medpeds Residents Association. This is a really cool organization in regards to medicine pediatric residents. And so I would assume a vast majority of you are interested in maybe either medicine or pediatrics. This has got great resources for that as well. I believe it's nampra.org. Don't quote me on that. But if you type in NMPRA, you'll find it. It's got a lot of amazing resources, educational and career advice wise. It talks about the field. It talks about what you can expect out of the field of med-peds, much more than my, year and a half, they're almost 2 years experience now in the field of med-peds. I would definitely check it out. I love AAFP, and I'm not just saying that because I used to love family medicine as my main field. Family medicine covers, very similar to emergency medicine, covers, and I guess med-peds as well, covers almost every part of medicine, which is why they're such cool fields. And in that respect, their website has so many resources on basically anything you can see in medical school, in your clinic, in the hospital, wherever, in your shadowing. And it's going to be a great way, in my opinion, again, this is only my opinion, to expose you to the kind of the breadth of medicine, the field of medicine. So I would check out those websites if you do have an interest. One question that popped up before, I just want to make sure that I relay, because it's one thing that was never relayed to me. I did say it earlier. If somebody had asked what's the best way to find shadowing hours, please go on Google, type in, whatever interest you're in, family medicine doctors near me, emergency medicine doctors near me, med-peds doctors near me, whatever. Look them up, find their email, call their office. A lot of times their email's not going to be there. Call the office and say, hey, I'm a medical student. I'd love to shadow. And I'd be so grateful if I could have the option to speak to the doctor, or email him or her and kind of make an appointment to see if this could be something. And for the most of the time, I think that doctors are really open to teaching, because the field is all about taking and giving education and passing it on. And my experience with it was great. I worked with actually 2 different doctors. One was in rheumatology, which really wasn't for me, and I was out of there in a month. But it was a great experience, because now I know I don't want to do rheumatology. And the other one was the family medical doctor. So that's the biggest, one of the bigger questions that popped up down here that I wanted to touch on. All right, let's see. Do I have any more slides?
Hey, Jeremy, a question has popped up several times from several of the students. By the way, you're at 650 almost people listening to you, isn't that amazing? That would be an auditorium full. What's your schedule like as a resident? I mean, you've already talked about the fact you're surviving on what kind of drinks did you say?
I don't want to.
No. I know
energy drinks.
Energy drinks. That's what I meant to say. No, I survive on the strongest, blackest coffee I can find. Yeah. So, what's your schedule like on a given week? I mean, are you you've got an 80-hour limitation, right? For your
I think in theory you do, but I'd imagine in and out of the hospital, between research, between volunteering, between my own studying, it's much more than that. It's at least 14 to 15 hours a day. I eat, sleep, breathe, and pee and poop medicine. I mean, it's my life, and I love it. It's all I can think about all day. And my dog Zeus, of course, I can't forget about. Sorry about that. So Day in the life. All right. So if I'm on an inpatient rotation, let's talk about inpatient rotations because that's primarily where my interest is. I'm up at 5. Okay. Maybe some of you have kids. Maybe you have a dog. Maybe you have chores you have to do. You're up at 5. Ultimately, from what I've heard and what's the kind of the deal at my hospital is you get there around 7 o'clock. So if you have stuff to do in the morning or throughout the day, you do it between like 5 to 7. I live about 20 to 30 minutes from my hospital because I like the location where I live and I chose it for that reason. So that means I really have, if I'm waking up at 5, I have like an hour and a half. And then if I'm really like, like I keep snoozing my alarm, it's creeping really close to an hour, hour 15. So that means I have an hour 15 to potentially shower, brush my teeth, go to the bathroom, eat breakfast, have a coffee, walk Zeus, get the mail, whatever, read up on my patients a little bit. So it's really eat, sleep, and breathe, especially on the inpatient ward. You get to the hospital around 7, and there's a night doctor there who's usually a resident. And he or she will say, okay, listen, this is what happened to your patients. You have 15 to 30 patients. You got 2 new admissions. One of your patients expired overnight, so you don't have to worry about them anymore. This is what happened to your patient. You put in this wrong order. So this patient went into a full-blown ventricular tachycardia. They required some intervention. So they're good now, but please don't do that again. And you say, okay, thank you for the patients. You take your patient list. You scroll through your chart. You say, okay, what were the vitals? What were the labs? Is there any new fluids that the patient's on? Are there any interventions that happened overnight that the resident forgot to tell me, or because they're a human being and that's okay to forget? Is there any cultures from the blood that came back? Is there any x-rays that I took overnight or this morning that came back that I want to intervene on and see what's going on before rounds happen? So I do all that. Then I go around and see my 15 patients. And sometimes the toughest part about seeing the patients, if they're not neonates, if they're my adult patients, is they like to be chatty in the morning. They like to wake up, they got their coffee, they want to chit chat you. And you're like, listen, I gotta go. I got 15 other patients to see, but here's what's going on. And okay, and they're kind of holding on to you and you're kind of trying to squeeze out the door. But you really want to give patient care and you want to be a good doctor. So it's kind of a push and tug there. So you see your 15 patients and then you make your plan in your head. Then your attending comes in and goes, yes, hello, or she, yes, hello, I'm coming in now, and it's time to round on our patients. And you get your cows, your computers on wheels, your cows, and you walk over to each patient room. And again, this is a ward environment. This is not going to be your classic emergency medicine environment or your classic outpatient medicine environment. Okay, this is a general ward, maybe ICU, any sort of kind of hospital floor environment. So you go around on your patients, you present, you say, this patient, this happened to this happened to this. And the attending, they read all of this stuff because they're super quick. They've been in this field for so long and they know all of this information already. They go, oh, really? Okay, yeah. So what would you like to do? And you say, I want to do this. And then sometimes the attending goes, oh, okay, that's good. Well, I already did that just now. So it's already done. Good job. You did the right thing. Or they say, well, I don't know if I agree with that. And then sometimes you have 2 people butting heads. If the consultant comes and you say, oh, I want to call the nephrologist because this guy's kidney function's terrible. And they come and they kind of argue a little bit and you come with a really good plan. And you do that for all your patients. And by that time, it's like 12 o'clock, maybe 1 or maybe 2, or even at one time it was 6 p.m. And I was so tired and so hungry. And you eat, hopefully, lunch, unless you're doing a keto fast, which I sometimes do. And you're even more tired and drained. And anyways, so you do that, you go back, you write your notes, you finish rounding on your patients, you respond to any crazy things that are going on in the hospital. 5 o'clock hits, all the attendings go home, only the residents are really left in the hospital. People decide, okay, now that you're about to go home, I'm gonna have some respiratory problems and I'm gonna pull you away from all the work that you have and I want you to come to my floor now and take care of me. So you're responding to all the rapid responses in code blues and code pinks and purples and yellows and oranges, and you're going all over the hospital, and 7 o'clock hits and maybe you finished your notes, maybe you didn't, but the night guy's here, the night gal is here, you gotta go over and sign out to your patients, to them. You tell them everything that happened during the day. They say, are you going to put any of my patients into arrhythmias again? Because I don't want to have to do any more interventions or shock the patient again. And you'll say, well, okay, maybe, I don't know. I like literally was so busy all day. I responded to 5 different color codes today. And I'm not even sure which each of the code colors are because I'm an intern and this is crazy. And I miss med school and I miss college and I miss home and I want to go to sleep. So that's your day. You get home, you drive, you walk Zeus, you kiss your kids, you call your mom if you have time or if you're not too tired. You call your grandpa who's now consulting you as a primary care physician and asking you everything under the sun and asking about his atrial fibrillation. And you're like, Grandpa, like, I don't know. Like, I'm like just an intern. I just graduated med school. Like, I'll ask my attending tomorrow. He goes, well, okay, but shouldn't you know this? And you go, well, I'm sure. So anyways, that's intern year. It gets better. You get swifter at it. You get more efficient. You have a good time. You start to enjoy what you're doing. You start to critically think. And then you get to senior year where I'm at, and you help people grow and you help people learn, and you help people succeed, and you do it all over again. And in most professions, you do it for 3 years. Some professions, you do it for 4 years. If you're a neurosurgeon, maybe you do it for 5 or 6 years. And if you go into a fellowship, maybe you're in there for 10 years. And then you eat, sleep, and breathe it for the rest of life, and hopefully have a family, and you travel and you still have a life, and that's it. I think I went beyond kind of day in the life.
No, that's all great. Jeremy,
philosophical.
How do you feel like you were a physician when you started your internship, but how do you feel like you've changed as a physician? Because you said something really important. You said you started as an intern, second year you did this, and as a third year, you're helping others grow. And I see that I've actually worked with every single one of the EM residencies here at Southwestern. And it's absolutely true. Interns come in, their eyes are as big as saucers. They can barely pour pee out of a boot. Their skill set is tiny. And by the time they're in the third year of their ER, they are sophisticated, smart, crafty physicians. How does that change happen?
Dr. Fowler, I'll tell you, it's weird. I wake up and I just do. I just do. And sometimes the day passes and it's 3 o'clock. And I was like, I did all that. How did that even happen? I go back to last year or to my mental breakdowns where I was questioning my career in medicine. And it's a tough process, but going through everything that you're doing, from shadowing to volunteering, to research, to doing all of your classes, your pre-med classes, to tutoring, to working, to dealing with normal interactions in your life, you're preparing for the challenges of residency, and you're equipping yourself to be the best doctor that you can be, and really the best human that you can be, because it's ultimately a humanistic job. And there is a large part of critical thinking, and that does just come with time, but it's just kind of dealing with everything that's going on and all the moving pieces. And you just do it. And when you can't do it and you can't figure it out, you ask for help, and you go to people who have been doing it for years. You go to people like Dr. Fowler, who've been doing it for years and love teaching and are in this field to make good doctors out of other people. And, I owe my life to not only attending physicians and professors, but I also owe it to the senior residents who are a year above me and who knew just from yesterday how hard it was, and applied and took time out of their day to help make me better. And that, combined with reading, combined with keeping sane, meditating, playing with my dog, you get through it and you do it. But it's challenging. It's really challenging. And, but it's so rewarding, and I love what I do. And I'm really tired, Dr. Fowler. I'm really tired, but I love what I do.
Well, we love what you're saying. All 630 of us that are sitting here listening to you, Jeremy. This is terrific. Did you love people? In terms of figuring out people who can come be doctors and train, I say, I don't need a genius. Give me somebody with reasonable aptitude. They don't have to be an Einstein, who has, kind of the Thomas Edison, that genius is 90% perspiration, a strong work ethic.
Sure.
And who's just a nice person. They like people. You give me that person, they'll make a great doctor out of themselves. Did you really like people this much? Because haven't you found that medicine is such close contact with the patients that you serve?
It is close contact. And a lot of times you lose sight of that because of how much workload that you have, but it really does come down to that. And I love that you brought that up. I don't think I was ever in my life the star student or near being the star student. I hung out in the middle of the pack, sometimes in the low middle of the pack, depending on the class. And I worked my butt off. I really worked my butt off from high school, even middle school, because I thought it's what I wanted to do. But as I grew older, I knew it was what I wanted to do. So I really worked hard at doing what I was doing. And yeah, there's so many geniuses in all fields, but in medicine, there's a lot of geniuses. But if you lack that social touch and that human component, you're not only are you not the ideal doctor for your patient, but you're not an ideal doctor for yourself, and you're really not fulfilling what the job of the physician really is. And the people that you work with, the amount of social interactions that you're having around you, not just with your patients and your patients' families, but the people that you work with. You need to be able to be a team player. You need to be able to interact like a normal person. And if you're not right now, if any of you are not feeling at that level, that's okay. That's something you can work on. I don't think I was always a quote unquote social person. I really grew into it because I wanted to. I wanted to have good interactions and connections with people. And I don't think it came naturally to me. I was kind of an awkward, geeky kid. I was in the band, but I wasn't a smart kid. You know, there's like geeks and nerds. I was a geek, but I was lacking the nerd, you know? So I don't think I was the classic piece of a medical student at all. You know, I went to a good school, a good college, but it wasn't a top college. You know, it's a good college. I think it's a good college, and I had a good time. I have no regrets. Did I go to a top medical school? No. Did I go to a really reputable school that'll give me a good education? Yeah, sure. It was a foreign medical school. That's okay. It happens. You know, mistakes sometimes happen when you're younger. You're not at your peak capacity when you're younger. So sometimes you're not going to end up at the top. And, you know, you always want the top doctor to be taking care of you. But if that top doctor hasn't lived their life, then how are they going to interact with you and experience what you're experiencing in the hospital and with your disease process and with all of your emotions really properly? I mean, it's so important. And I guess until I can say that from a patient perspective, because I've been a patient kind of all my life with my diabetes. But it's so much more than the medicine. Definitely, Dr. Fowler. It's definitely more than the medicine. And again, whenever I do these talks, I really want to stress that make sure what you're doing is what you love and what you're passionate about. Only you can really determine if this field is right for you. Nobody can tell you. I can't tell you how many guidance counselors says your applications are not really where they're meant to be. They're not really there. You're not really going to be a good doctor. I can't tell you how many people beat me down. And you know what? I say thanks to them because it made me stronger. It made me prove them wrong. And I'm here now, and I'm so grateful. And whenever I'm feeling down, I remember back to those days and how far I've come. And I apply that positivity to the patient care and to my patients every day.
So have you become a doctor? I mean, it's an interesting thing because you weren't when you were playing in the band and hanging out, doing the nerd thing and that sort of thing. But with this tremendous dedication of hard work and reading and studying and seeing thousands of patients that it takes, do you make a change where you become a physician? I think you do. That's my opinion. But so much of it, Jeremy, is the humanitarian piece of it, is that you give yourself over to a cause that's bigger than yourself. I don't mean to be corny, but I think it's true.
No, I've been corny all night. I promote corniness. Totally. I'm actually one of the most sarcastic people ever, but for some reason, when I get into these talks, I get really passionate and emotional, and very corny. So I'm all about the corniness. So please continue with it, because then I won't be the only one that looks too corny. Yeah, you know, I think you do become a doctor, and you know, I can't speak at the level that you can, Dr. Fowler, but you know, I feel certainly like I've had some sort of major transformation. I don't feel like the person that I was last year. Do I feel tired? More tired? Yeah. Do I feel a little bit more jaded? Yeah, maybe, because my hours are crazy. but do I feel like I can really take care of patients? And if you hand me a patient with this, this, and this, can I deal with this, this, and this? 100%. I feel very good about it. And when I don't know, I know who to ask. And that's what I think, that's just a skill that you get along the way, right? When you don't know what to do, you ask for help. It's learning about resource management and learning about knowing what your strengths and weaknesses are that get you to that point.
So the good news, at least, is that you're going to learn the body of knowledge, and then you'll never have to read and study again, right?
Oh, I wish. Unfortunately, there's people out there who want to keep making medicine better and keep researching things, and that makes me have to learn and read up on journal articles every day. And boy, am I already tired, but you know what? If it's for the better care of my patients, 100% I'll do it.
I'm pushing 70. I'm still full-time clinical practice. I don't think I'm going to stop. And I read 3 and 4 hours every day. I have to. And that, I think it's a lifelong commitment to study. I think if you don't want to be a doc, if you want to be a doc, you're going to have to commit to that, because if you don't commit to continued study, you're not going to be able to keep up. Jeremy, I'm walking on your talk. Go ahead and take your talk.
No, I would prefer you to talk and me to touch on it, because sometimes I flow and sometimes I hit a wall. I think I just hit a wall. Is there any point where I answer any more questions in the chat, or should I keep going? I have so many slides.
Okay. I'm going to shut up. Reagan, take it
away. No,
away.
you're great.
we have 50 questions for you in chat, literally right now. So many outpouring of wonderful questions. Reagan, take it away. Take it away.
Okay, we'll ask a ton of questions. How about that?
Yeah, bring it on. Yes. Rapid round, speed round.
Okay, deal. So did you ever think of becoming an endocrinologist, since you are type 1 diabetic and that's something that you have had and dealt with and, been a patient with your whole life?
Yeah, that's a really good question. I wonder if this person's a diabetic themselves. But if that's what you're passionate about, you should totally go into it. I did think about being an endocrinologist for a long time because that's what I knew. But then I got exposed to the whole field of medicine. I was like, this is crazy. I want to do all of it. And that's why I want to be a general internist or general pediatrician, because I want to see everything. I don't want to expose myself just to one thing or another. That's why I did Medpeds. I want to do everything. I want to see everything. And I want to live, sleep, eat, and breathe it. And that's just me. It doesn't have to be you. Now, the question was, do I want to be an endocrinologist? No, I'm really sick of diabetes. Do I like endocrinology? Sure. Whenever I have a diabetes patient, especially on the pediatric floor, who comes up, they're newly diagnosed, do I go chat with them for an hour and tell them it's all going to be okay? Hell yeah, of course I'll do that. But do I want to deal with diabetes management all day? I don't. But I appreciate the field, and I consult endocrinology daily for questions because I don't know. I don't know all the answers, even though I'm a diabetic.
Gotcha.
Okay. Next question.
Okay. A lot of people wanted to know, how was it like going to medical school internationally, and what were the challenges transitioning back to the United States?
Yeah, good question. I've got to tell you something. All of my good friends from my medical school, obviously, were international because they all went to med school with me. But a lot of my, good friends here at Stony Brook all went to international medical school. I think it's a great option. Is it the right option for everybody? No. There's also DO schools, there's MD schools, there's also PA school, there's also nursing. There's literally everything under the sun you can go to. Do not stop. If you don't get into a med school, do not stop. I know friends of mine who applied and went, took multiple years to get into and waited for an MD school and built up their resume. That's fine. I loved what I did. I'd never change what I did. I had an amazing experience in Israel. I learned a new language. I interacted with a new culture. I think it makes me a stronger physician. I spent time away from my family, which was really tough and kind of made me be a little bit stronger and have a harder shell, which actually prepared me for residency with tough personalities and dealing with really tough situations. So no, I think it's an amazing experience. I know there's amazing Caribbean schools. St. George is a really good one. I have a lot of friends from there and who say great things about it. If you work hard, you'll be really surprised at what you can achieve. So if you do end up at an international medical school, make the best experience out of it, work your butt off, learn, live your life outside of it as well. It doesn't really matter where you go. I've met amazing doctors that went to random schools, for example, in India. the best doctors ever. One I'm working with right now. And I've met really terrible doctors who went to some of the Ivy League schools who I don't want to see again. I've also met really bad doctors that I didn't really like that were from international programs too. So it depends from person to person, but ultimately, if you want to be a doctor and you don't get to A, try B. And if you don't get to B, try C. And if you don't get to C, go to D, E, F, G. Keep trying, okay? It's awesome, okay? Go into medicine within any field, within anywhere, international or not, okay? All right, I'm done talking. Next question.
That was a great answer. You know, we're all going to end up where we're supposed to be.
Okay.
So the next question, was matching to a residency program more difficult or competitive since you went to an international school?
100%. It's definitely more difficult. But did I match into a program where my counterparts in MD and DO schools matched? Yeah. So what does that say? It really says how important the application process is, how you look as an applicant, also your scores too, right? They made some recent changes to the USMLE, which we can touch on later if there's time. But it can be more difficult, yeah, 100%. But if you work hard, hopefully you'll end up somewhere. No matter what, just end up somewhere and be a doctor. You should not, if you care about where you go to school as a doctor, I don't know if you should be a doctor, because you shouldn't be going into it for prestige. You should really be going into it for yourself and for your patients and for living such a great life that's there to help others. Now, is going to a top tier school bad? No. Would I love to go to Harvard? Yeah, sure. Why not? It's kind of cold over here on the East Coast. I miss California. Shout out to my Californians in the chat. But ultimately, no. It's harder, but it's okay.
Okay.
Next question.
You mentioned struggling with intubating. How do you keep up your morale when struggling with different skills, especially when it takes a while to learn them?
Yeah. So at my hospital, doing intubations is not really common unless you're in the NICU. I can't say there's another place, and I go to work in like every ICU basically, besides like the SICU and the neuro ICU, the surgical ICU and the neuro ICU. We don't do intubations except in the neonatal ICU. So, I think I've attempted 8 times in my life. I did one successful one on a baby that had passed away. So great. But when you're working with a squirming baby, it's tough. And again, when you're dealing and you're hitting these walls and you're hitting these tough moments, it's not that you're hitting these tough moments. It's really how you deal with it and how you experience it and how you learn from it and how you go around those walls and try to jump over the next wall. So if you take every experience you have as a learning experience and say, you know what, now that I learned that I shouldn't do this, thank the Lord that I learned it, because I'm not going to do it again. And now next time I'm going to go the other way. I think I got my anatomy mixed up on my last intubation, and I went over the epiglottis rather than under it for some reason. I think I was nervous. And I thought back and I said, how in the world, I went to medical school, did I miss the larynx, the airway? What is wrong, or the trachea? What is wrong with me? So you kind of laugh and you say, okay, that happened. And you better bet the next time I'm not going to go above the epiglottis. I'm going to go below it. Some of you might not know what that is. Some of you who might know what it is can laugh with me. So yeah, you kind of deal with it. You deal with it and you come up with coping mechanisms. When I have a really tough day and all my coping mechanisms don't work, I go over to Zeus and I give him a big hug. Aww. And usually he just asks me to go for a walk at that point, but I've got a good hold on him for 5 seconds that I get enough endorphin release that I feel better.
So do you think being in the field of pediatrics makes you more emotional when it comes to having to deal with sick children or sick patients?
It's really interesting. In my intern year, I think I was so emotional from my own struggles that I was more empathetic to other people's struggles. And I found myself leaving patient rooms sometimes and like shedding a few tears. You experience it so much that I think the empathy is there, but the feeling, I guess it becomes more sympathy to some degree. Do you still experience empathy? Yeah, but you become more acquainted with it. And so it's a kind of a different relationship that you have with the empathy. So, you know, I imagine, you know, each case is different and the connections that you build with each patient is different. So that level of empathy you have with each patient's case is different. And so like today out of nowhere, like I shed a tear when a mom was crying when we told her that her baby who we thought had brain damage didn't have brain damage. And I was like, why am I crying? This is weird. And I hope nobody looked at me. I wiped a tear and I continued writing my notes. It's weird, you know, it's weird. I think it's an ever-growing process, and I'm sure Dr. Fowler has gone through many transformations. And it's funny, you know, Dr. Fowler had mentioned, like, when do you become a doctor, or do you become a doctor? And I think it's, you know, I'd imagine that you're always kind of becoming a doctor. It's just kind of a better version of it. Hope that answers that question.
Yeah, I think a key point, Jeremy, I think a key point, though, is that we are in the business of dealing with humanity. And if we either don't know something or we get something wrong, we got to fix it. You know, we got to either study and learn it or learn the skill, learn the trade, you know.
Right. Right. You got to be comfortable with being uncomfortable. Somebody said to me once.
Reagan?
So the students really want to have a Zeus reveal. Would you be comfortable with that? I mean, you don't have to show us your like bed or whatever, but maybe like, you can put him in your lap or something. That might be better. I don't know how big he is though.
So Zeus is 105 pounds now.
Oh.
So unfortunately, I can't lift him up into my back, and I like don't have time to work out recently, so I'm not about to like get a hernia. But I will reveal to you Zeus. I will reveal you to him. If you don't judge me, because I didn't make my bed. And all right, I'll leave it at that. Here we go. Unplugging computer.
Guys, we're not going to judge him, right? Everybody,
no judgment zone. I'm covering the camera with my face. Here we go. I'm moving the lamp over here to see Zeus.
The mighty Zeus.
The mighty Zeus. What are you
doing? Oh, he's so cute.
It's so cute.
There you go. He's kind of boring. He usually does a show. He can do some tricks, but my friend had him all day, and he's really tired because she likes to take him on runs, and I take him on walks because I'm out of shape and in residency. All right, next question. Zeus reveal is over. That's kind of the peak of the night. It's all really downhill from here, I guess. That's like the one main question I got. Nobody really came to this talk to hear about Medpeds. They came to see Zeus, I guess. But
okay, so let's see. So some of the students are a little confused. So whenever you are an attending, will you be working in a hospital or in a clinic or either?
Okay, so let's review kind of the order of things. You go to college, you go to med school, unless you have one of those cool, hip, smart people combined MD, BA, or BS programs. Then you do a residency, which is a training in your specified field. So in medical school, you're getting exposed to every field, and you're doing clerkships in these big rotations for a month or two. Residency, you're doing rotations that are pertaining to your specific field. And then as an attending, that's when your training, formal training is done, and it's usually self-directed learning. You can work as a primarily outpatient physician. You can buy and have your own clinic. You can work for an urgent care clinic. You can work for a small community hospital. You can work for a big community hospital. You can work for a little academic center. You can work for a big academic center. And then the list goes crazy on from there. You can practice wilderness medicine. You can practice, I think there's like marine medicine. You can work on a cruise ship and be a cruise ship doctor and sail the world. You can live in your home and travel the world and be a telehealth doctor now. Thank you, COVID. You can really do anything. So being an attending is really kind of your own definition of it. I'm more attuned to being an internal medicine doctor, or rather a hospital doctor, a pediatrician, an internal medicine doctor in the hospital with acute patients who are like usually sick. with some ICU care, with some really sick patients who need some really close attention. When it comes to outpatient care, that's very important, and both crosstalk because both need to know when to send the patient to the other. And there is it's kind of like a Venn diagram. There's some crosstalk between the two about what they can manage. So they're not kind of mutually exclusive. They're kind of mutually inclusive. I think that's the right way to say it. So it's really dependent on what you want to do. They recently came out with this weird rule now that pediatricians can't be hospitalists unless they do a fellowship. And I don't want to do more training because I think that I'm really tired. I'm doing a lot of it already. I'm getting a good experience in inpatient medicine. And that being said, I'll probably end up doing inpatient adult medicine, and then on my off days, maybe do some urgent care in the pediatric community, something like that. And so you can kind of make it up as you go, which is something really cool about medicine, which is very cool. You're like a private kind of contracted, and you can kind of do whatever you want to do.
And then, so obviously a lot of things have changed because of COVID. How have your interactions with your patients at the hospital changed, just broadly overall?
Yeah, I mean, immensely. I think visitation policy has changed dramatically. So you're really dealing with patients primarily and not necessarily their families. You're dealing with limited amounts of patients. Again, I'm swabbing every patient that comes in to see if I need to isolate them from other patients. If I do have a patient that has COVID and they have something else, but they also have symptoms that are kind of both, what do I do in that situation? What's causing the symptoms? Is it both? Is it one? Sometimes surgeries were postponed in a lot of cases so that the surgeons could come work for COVID floors. For a while, I was swimming in COVID and just had COVID patients. I was working on an ICU, on an ICR, which is kind of like a step down ICU for less critical patients who are kind of critical. And I was doing that for months, in garb all day when we didn't know anything about the virus. So being sweatier, I think, is a really big part of COVID in the hospital. Acne is now a big part of, from the masks. Poor vision from all of the fog on your goggles is a big one. But for a while, and I can't speak to other institutions, but at our institution, COVID numbers have kind of leveled out, and residents are now working with a broad range of patients rather than just being dedicated to COVID units and COVID floors for months at a time.
Gotcha. I think we'll do one more, and then I'll let you go on to the case studies.
Oh, we'll do the case. Okay. Very good.
So, what is some advice you have on the differences of working with pediatrics versus adults?
Yeah, that's a really good one. And I don't think that was a question that I properly answered for myself before I went into the field. Pediatric patients tend to be healthier, and the vast whole tend to really be healthier. They tend to be really resilient. Their bodies can adjust to being ill very well. And a lot of the patients that you see on the floor on the pediatric side are really not as sick as the adult side. One of the reasons is, again, they're resilient. They haven't developed their bodies to the full extent to develop all of these conditions. And also, they don't really have a lot of comorbidities. They don't have a lot of conditions that are all interacting with each other and making the presentation of their main illness worse. So there's that perspective. From another perspective, when you're dealing with pediatric patients, you're dealing with mommies and daddies a lot, when you're dealing with parents, guardians, and it's a lot of making parents feel comfortable with what's going on rather than talking to the patient and dealing with them personally. If I ask a kid, oh, how are you feeling? A lot of times the kid will look over to the mom. Okay, that's weird. You're not going to tell me how you feel. Your mom's going to tell me how you feel. So there becomes that battle too. So being a pediatrician is not, again, like Dr. Fowler and I were saying, it's not just about the medicine. It's about the human component. It's about interaction. You know, it's an art of getting the details out of the patient, interacting with them, and figuring out a way and a style that works in being efficient and getting to the bottom of what's going on with your patients, treating them, and being a good human to them and making them feel better from a mental, emotional, spiritual standpoint while they're in the hospital. So I would say that there's a bigger social component in pediatrics. If we did social and medical, I would say medical social is higher in adults, and social medical tends to be higher in peds. So that's a big thing, I think, to keep in mind. But I like both. So
yeah, I think a lot of people forget about, you know, working with pediatrics. There's a much bigger social requirement that you have to fill for that one. Well, thank you for the wonderful Q&A. I am going to hand it back over to you for the cases.
Okay. All right, here's another nice stock photo of a cute kid with a stethoscope and a bear, pulling at your heartstrings, getting you guys all revved up for the case. Let's talk about this case. Perfect, thank you so much. You're so good with this. Whoever's on the slides right now, thank you. Is that Reagan? Thank you, I'm on it. You're like reading my mind. So this was on the pediatric floor. This was about 2 months ago. I had a 14-year-old kiddo. All right, so like teenagers, you can talk to them. They're mostly good, and unless they're moody, then they're not as fun. He's coming in. He went to his primary care office for a fever for 20 days of fever. Imagine when you've had fevers like the flu or the cold, maybe it's once, twice, 3 days. 20 days, this guy's had fevers. Why? What is he just getting to the hospital for? Next slide, please. Thank you. So he's had it daily. He's had a Tmax, which is what a fancy term, I guess, for the maximum temperature of 103 degrees Fahrenheit. That's a high temperature, okay? Especially for a 14-year-old, that's a pretty high temperature. He's had some night sweats, so he's sweating at night, which is a key in a lot of conditions, as you guys will learn in medicine. He's had headaches, pretty general complaint, malaise, just fatigue, weakness, anorexia, which you guys might know as that illness, but anorexia without the nervosa just means you don't want to eat, you don't have an appetite. And he's had diarrhea. That's non-bloody, and that's always important in medicine. You want to know if it's bloody or not, because that'll point you into a direction of what's causing it. Usually if it's bloody, it's a bacterial cause. He's been taking Tylenol. Okay, so he's smart to some degree. This guy's been taking Tylenol, or his parents are smart, to bring down the temperatures. And probably the Tylenol is helping with his headaches too as well. Especially if and then maybe the anorexia if it's related to some abdominal pain, but he didn't report that, so maybe not. Of note, he went to Pakistan 2 months ago, and he had this little 14-hour layover in Istanbul. Always important to ask exactly where you met, because you don't know where the symptoms could have been picked up, or where the disease could have been picked up. If it is a transmittable disease, that is. I'm seeing some really cool differentials down at the bottom. Good job, guys and gals. I say guys a lot. You guys know I mean guys and gals. So he saw the PMD a week ago. I guess they did a strep culture, and he had a positive strep throat. But you know, if you do those rapid tests, a lot of these tests, they're not accurate. Even COVID tests, they can sometimes say positive or negative, but they're actually might not be. So you have to use clinical judgment. You have to look at the whole picture and see, is this test really telling me what's right? Or should I use my brain and my studying of 4 years to figure out if this is really what's going on, okay? So he had this strep throat. He took some amoxicillin. Thank you so much. We can change. Nice picture of check marks there. We're checking off things. So this is a review of systems. Doctors, you know, I'll ask everyone a few set of questions. Do you have headache, blurred vision, changes in hearing, sore throat, cough, neck pain, chest pain, shortness of breath, abdominal pain, nausea, vomiting, diarrhea, chest pain, shoulder, whatever. I go through a list in my head that's like literally a script, but I don't cover everything. So I got to go through a review of systems, and that's to make sure I cover all of my bases. Remember, we're just humans. Doctors, I used to think doctors were superheroes, but they're really not. We're just normal people with big egos. Just kidding. We care about patients too, okay? We also care about patients. Don't forget that. Constitutional wise, fever, weakness, fatigue, weight loss, we covered that. Night sweats. He also had some cough. I think we covered, luckily, in our general asking of questions, did this guy have these symptoms? And the answer was yes, okay? So he had all of these symptoms that I had just mentioned. Next slide, please, thank you. So his temperature when we checked him in the emergency room was 38 degrees Celsius. Celsius, right? There's Celsius and there's Fahrenheit. 38 degrees Celsius is a fever. Okay, that's definitely a fever. And it's a minorly elevated fever. It's nothing crazy, but it is a fever. His heart rate was elevated. Okay, he was tachycardic is the word. So his heart rate was really fast. If you take your heart rate, it's like 60. So that's kind of quick. 60 to 90 is your heart rate. Depending if you're nervous like me, then it's like 90. Or if you're taking energy drinks like me, then it might be 116. Then you should consult a doctor. Respiratory rate was normal. A normal respiratory rate is like for an adult. And he was a big boy. He was like a big kid. So like 12 to 20. His blood pressure was low. Okay, that's low. You want it really, you can technically say greater than 90 over 60, but you really want it in the 100s, 1-teens, especially as a kiddo. So this kid was dry. What do we mean when we say dry? He was volume depleted. This kid needed fluids. His pulse ox was okay. He was breathing okay, right? Not like that baby I saw in the NICU. He was breathing okay. He was saturating at 96%, right? Remember, in the 90s is roughly where we want our kids and adults, really everyone in the 90s. That's where humans live. All right, physical exam. Every time you see a patient, you want to just look at them, okay? Don't jump to the patient, look at them. Do they look sick? Do they have a rash? Do their eyes look funky? Do they have any weird congenital features? Is maybe their symptoms related to that congenital condition? Are they disheveled? Do they smell? Do they wash their body? What's going on, right? If this guy's like really thirsty all the time and he's disheveled, maybe there's something else going on. Maybe he's just kind of a weirdo and he likes to drink water all the time. I don't know. You have to take all these things into account, okay? I'm just made up a patient. Don't take that what I said seriously. Generally, this kid was in no acute distress. He was like a teen. He was sitting in bed. He was like this. Hey, what's up? He was like that. His pupils were equal, round, and reactive to light. So we shined a light, made sure they opened and closed. The pupils looked good. Everything looked good. Normal conjunctiva. He didn't have red eyes. We felt his head. It was normal cephalic. There was no, bruises, trauma, nothing there. Looked in his mouth. It was moist, meaning there was a good amount of fluid in his body, but for some reason his blood pressure was low. So we'll get into that a little later, okay? Respiratory wise, I listened to his lungs. Good sounds. I didn't hear any weird sounds like crackles or wheezes, like asthma, pneumonia, or like a weird amount of air in a certain pocket of his lungs. Okay. I looked at his heart, right? I listened to it. Normal rate. Boom, 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 boom. I'm sorry. Normal rhythm. Tachycardic rate, right? He was really fast. And I didn't hear a murmur. What's a murmur? If your heart goes like this, boom, 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 that's normal. If it goes like this, boom, 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 boom. If there's other sounds in there, that's a murmur, okay? Gastrointestinal wise, I felt his belly. It was soft. It wasn't tender. He was like, it's fine, whatever, dude. Why are you touching my belly? Musculoskeletal wise, I felt his muscles. There was no swelling, no deformity. He looked normal. No rashes. Okay, that's a big one. He didn't look ill or have any sort of hives or any rashes or any signs of cellulitis, a skin infection, nothing like that. And then neurologically, he was alert. He was also oriented. He knew where he was. He knew his name. He knew he didn't want to be here. He knew he was a moody teenager. Psychiatric wise, he was cooperative for the most part for a teenager. And he was appropriate. He was acting normally. He wasn't like, woo, acting weird, right? Any questions? All right. Yeah, it's a lot of weird stuff, right? Okay. What's the medical term for what this patient is experiencing? So he said autoimmune, I see. Okay, good guess, good guess. There's a really good mnemonic called Vindicate to think about a differential. Look up differential diagnosis, Vindicate. And whenever you have a condition, it'll run you through all the different systems. That's what I run through in my head, Vindicate. It's a mnemonic. What is the medical term for what is this patient experiencing? Well, he's had a fever. It's for 20 days, which is a really long time. And we don't know where it's coming from. What's causing this? He's been worked up. He's seen doctors. So what's causing this? So it's a fever of unknown origin. Okay, that's the name of it. Okay, it's an FUO, not a UFO. Ha ha ha. So it's a fever of at least greater than or equal to 8 days, greater than 38.3. Okay, remember in the office, or rather in our ED, he was 38.1. Don't get technical on me. Okay, if fevers go like this, they go up and down. I might not have to be a 38.3, but he's had fevers. Okay, we believe him. He seems like a quality stand-up guy. Fever without a source is another name if it's just less than 8 days, okay? Next slide, please. What could be some of your differentials? So this mnemonic is called Vindicate, okay? We think of different diagnoses for a patient, different things and systems that can be causing what's going on. So Vindicate covers a few different fields: vascular, infectious, neoplastic. Is it a cancer that's causing it? Is a term for neoplastic. Is it degenerative, like osteoporosis? Is there a defect in some sort of mineral? Idiopathic, meaning we don't know what it is. It's idiopathic. You can think of it like an idiot. He doesn't know. Idiopathic. Is it congenital? Is it something he's had since he was a baby? Is it cardiac? Is it something related to his heart? Is it autoimmune? Someone said autoimmune. Is it related to your body's immune system attacking itself? Just like the cytokine storm sometimes can be in MISC, right? Is it traumatic? Is it related to an accident he had? He got hit somewhere, right? Is it endocrinologic? Is it an endocrine system disease? So every time you see a patient, and throughout your experience of seeing patients, your mind's gonna wanna go, I've seen patients like this before. I think it's pneumonia. Somebody said cholera. I think it's cholera. That's good. It's good to have clinical suspicion and clinical inclination to say, this is what I think it is, but that doesn't mean you can't rule out everything else that's going on with the patient. So that being said, you have to go through, mnemonics like Vindicate, make sure you're covering your bases. So yeah, this could be infectious. This could be a vasculitis. This could be a cancer. Sure, you could have a fever that could be caused by a cancer. That was on the differential. What else? It could be autoimmune. Sure, I guess potentially you could get a fever to some degree, especially if there was a superimposed infection. It could be endocrinologic, maybe. So we went through all these diagnoses, but this guy traveled. That's a really key part of the history. Anytime someone travels to a foreign country, you go, they have diseases, animals, people over there that experience kind of a different environment than we do, and therefore they have different sort of conditions and environments and living organisms that live there, so they could bring that to us. So that was at the top of our differential. All right, next slide, please. All right, so look at this beautiful slide. I love Google. If you need to figure out something really quick, biology, chemistry, psychology, anything, please use Google, but please also use your brain and knowledge and make sure it's an evidence-based source. So I use Google to kind of figure out a rough idea of what I want. And then once I say, oh, this is a differential that somebody came up with, I see polyarteritis nodosum. I'm gonna go look up what that is online, not Wikipedia. Maybe I'm gonna go look it up in a medical textbook or my biology book. So you can see, the differential is really vast. All right, we have infections, neoplasms, like they said, autoimmune. Look at all these different conditions. I'm not gonna go through all of them because there's a lot here. But a big thing we're thinking was infectious. All right, next slide, please. All right, so what do you want to do? Now, what's really important, I think this was a show that old people used to watch. I saw it online.
Hey, be careful there, would you?
Oh, sorry, Dr. Fowler, sorry. I saw it online. Again, it's one of those Google images I picked up. And essentially, when you're dealing with a patient, especially in the ER, and I really shouldn't be talking about this, especially with Dr. Fowler, who says he's pushing 70 and he's been in this field for forever. So I'm gonna be very careful about what I say in regards to ER medicine, is you have to make sure when a patient presents to you, wherever you are, that you're making sure they're stable. Yeah, I wanna figure out why he has this fever, but this dude, he has his blood pressure at such a low level. I don't know if he's septic, if there's an infection causing this. I don't know if he doesn't have enough volume in it. I have to deal with this now. So what did we do? We gave this kid some fluid and his blood pressures came up to the 110. Good, he's good there. We also gave him a Tylenol, take care of that fever, take care of any pain or muscle aches he was having potentially. That's kind of what solved that. We also did a very key thing that's not gonna give us a report right now. We took a blood culture. We took a culture of his blood that we're gonna grow on a plate in a certain sort of agar, in a certain sort of material that's gonna feed bacteria that are living in his blood that are gonna come out. And then we can, when they grow, we can look at them in the microscope in a few days and say, oh, maybe this is what's causing it. All right, so we did a blood culture. We also did some basic labs in chemistry. We'll get to that in a sec. All right, so this is kind of what you're thinking, right? So when you're an ER doctor or when you're screening for patients, even in the outpatient clinic, you have to decide, can I deal with this patient right now? Or should I send him to somewhere where they're going to have monitoring, someone to monitor his pulse ox, someone to monitor his heart rate regularly, someone to monitor his breathing, someone to lay eyes on him at all times. Can I do all that if I'm an outpatient physician and I have 6 patients in my waiting room? Probably not. So I'm going to send that patient to the ER. Okay, then the ER gets there, and the ER has a really big task. The ER is literally the gatekeeper of the hospital. They're going to decide if you stay or you go. And there's really no in between. There are a few cases that stay in the ER for a little bit, but I haven't really heard of a case that stays more than a few hours. Correct me if I'm wrong, doctor, or a few days.
Hey, Jeremy.
Yeah.
Why does a hospitalist make a lousy third base coach? Because he thinks everybody can go home. You can explain that if you want to.
So, right. So the hospitalist job, we have a certain limited number of patients in our beds. And Dr. Fowler downstairs, he sends the patients up to me. But I'm only one guy. I'm only one gal. I've only got a certain amount of beds. I have a certain amount of nurses. I can't keep all these patients here. I want to send anyone home immediately as soon as I can because 1, I don't want to deal with them. I'm tired. And 2, I got 6 patients downstairs in the ER waiting to come up and see me right now. So I want to get rid of these patients now. Also, that patient kind of talks a lot and keeps me in the room for like 2 hours and I can't get my work done, right? So you got to think about all these things. There's a lot of moving parts working as a doctor. So what are we going to do? Are we going to admit to the hospital or are we going to do an initial workup? What do you guys think? I'll look in the chat. Should we send home or should we admit to the hospital? I see an admit, initial workup, admit. Yes. Wow. Oh my gosh. A lot of future doctors here. Yes. We need to admit this patient. This guy's got low blood pressure. Yeah, sure. The fluids seem to have helped his blood pressure, but if this guy hasn't been eating well or drinking well, it's not going to be up for very long. And Dr. Fowler is going to be really mad at me if he admits this kid. I send him home and he's back the next night and he has to write a whole nother note on the same patient again, right? So you have to think about all these moving components, okay? So we're going to admit this kid to the hospital. We're going to follow up these blood cultures that we're going to take. We're going to look at these initial labs that we're going to take to see what is going on. All right, look at all these numbers and my big face is in the way. All right. So let's look. All right. So on the left, you see what is called a complete metabolic panel. What does that look at? It looks at electrolytes. It looks at your liver function, and it looks at some other components as well that they've added at the bottom there. One of the things is a troponin. You see a cardiac troponin there, and that's normal. Anything in red, you can probably determine that is bad or it's abnormal. Okay. Anything in gray is normal. So his cardiac troponins are okay, meaning I have little concern that there's something going on with his heart, right? If you have a bad heart, sometimes that can cause your pressures to be low. So his heart's okay. I don't have to call cardiology. That's good. BNP is also a measure of your heart function as well. His ALT, AST is elevated. Does anyone know what those are? ALT and AST? Let's see, liver enzymes. Yes, they're your liver enzymes. And anytime you have an infection, and sometimes any sort of inflammation, your liver enzymes can be elevated, but a lot of times it's a clue for a viral infection. So, all right, docs, keep that in your head. Maybe this is a virus. All right, let's look at his creatinine. Oh my God, it's 0.08. That wouldn't be too scary to Dr. Fowler dealing with mostly adult patients, but certainly in kiddos, they have different creatinine levels. So this kid does have some kidney disease. Yes, exactly. Ashley V. That's right. His glucose is a little high. Okay, that could mean a lot of things. Is he a diabetic? I don't know. Maybe his glucose is high, but maybe that could be from an infection. I don't really know. Let's look at everything as a whole. What about his sodium? His sodium is low. Sodium is such an interesting electrolyte. It's one of my favorites. I think most hospitalists love sodium. And I would imagine everybody else hates it because we get consulted for sodium all the time. This kid's sodium is a little low, not too bad, but something to think about. It can be caused by too high volume, too low volume. We have to think about all these things, right? But if this kid has low blood pressure, we're thinking this kid probably has low volume. So maybe this low sodium is caused by low volume. And when you have low volume, that means you have poor perfusion of blood to your kidneys, causing liver injury. So maybe your creatinine is going to bump a little bit, right? And if you have poor perfusion to your liver enzymes are going to bump a little bit, right? So what's causing all this? A lot going on here. I'm not really sure. I'm just a pre-health student. I just took Bio 101 starting yesterday, but let's figure it out anyway. His hemoglobin is low. Interesting. What's hemoglobin? It's a measure of, we talked about this earlier, your oxygen carrying capacity in the blood. It's your blood products that carry oxygen to your tissues. It's a little low. So maybe that's why there's some injury to this liver and the kidney. I don't know, maybe. And we look at all these other components. I'm not going to get into it. But essentially, the big thing here is his white blood cell count is normal. And that threw me off because I thought this kid, I could have sworn he had an infection, but it's normal. So that's weird. Now I really don't know what I'm doing. So I honed in on infection, right? That one person honed in on cholera, right? But now I don't know because it's normal. So what the heck's going on? Next slide, please. All right, so these are his coagulation products, right? So your blood needs to be able to clot appropriately, right? It needs to be able to form clots. So it's having some trouble there. That's what those numbers say. And the D-dimer is a lab that basically says, it's really confusing. It can say you're having clotting issues or coagulation issues, or it can say literally nothing. Or it can say you have inflammation. It can literally say everything and nothing. So being a doctor, again, you can't look at just one value at a time. You have to look at the whole picture. I wish it was easy because then I could probably sleep more and get out more and do this from my house and hang out with Zeus, who's still passed out snoring. Please be quiet over there, Zeus. All right, CRP is high and ProCal is high. These are inflammatory markers. These are some cool little enzymatic markers that can basically tell us, is there inflammation in the body? Again, that's so general. Inflammation, of course there's inflammation. This guy's coming in and he doesn't feel well, he's had fevers. He's in the hospital. Of course he's got inflammation, but the level of it can tell us a lot. That comes with experience. Look on the right. Wow. Now this is the first thing that I like. I'm a med student. I've seen some of those. Influenza, I've heard of that before. And I've heard of COVID-19 before, and everything else looks like some sort of pig Latin I've never seen before. But everything looks negative, so I think that's good. And you're right, it's good. But guess what, kids? This viral panel does not cover all viruses. So it tells you a lot, but it tells you a little too. So you still got to figure out. I'm still like, dude, what is going on? Next slide, please. Thank you, Reagan. Whoa. This is a chest x-ray. Oh my gosh. What am I looking? What is that? An arm? Is that like a heart in there? Is that a leg? Oh, someone said pneumonia. Interesting. So guess what? This is a chest cavity, okay? You look in the middle, that line that goes straight down, that's your spine. And right in the middle, that little globule, that's your heart. Now, if you look at all the little lines on the left and the right, those are your ribs, okay? So this is a pretty cool thing, okay? This has been around for some time. I can't speak to how long. Maybe Dr. Fowler can tell us when the chest x-rays were made soon after he became a doctor. I don't know.
Exactly, about 100 years ago.
I'm sorry, I'm using, you pulled me out for the guitar.
Yeah. No, that's all right.
So if you look at everything going on here, and you're an experienced radiologist, it's actually a normal chest x-ray. Something we talk about with x-rays is penetration, which looks at how well the x-rays kind of go through the body. And that's something you have to keep in mind too. Now, you look at those little kind of squiggles on either side of the heart, and I kind of want to say, oh, that looks kind of funky, but you know what? That's real, or that's normal rather. That's just normal. It was red as normal. Sometimes a little bit more of that can mean you're a little congested. You have a little fluid backed up from your heart. But right now, it's actually normal in this kid. And depending on the penetration of how that x-ray is hitting you, can actually be normal. So this is a normal x-ray. So someone who said pneumonia, okay. Pulmonary embolism, that's tough to see. I saw someone put that. That's tough to see in an x-ray. There are certain signs you could see, but it's not very sensitive at picking it up, unfortunately. Wow, I'm seeing a lot of really high level, the squigglies, that's funny. I'm seeing a lot of high level comments in here that don't sound like college kids. It sounds like medical students. I'm very impressed. I did not expect to see all these high level answers. Maybe I should up the way I'm talking here. Reagan, next slide, please. Thank you so much for doing these slide changes. I appreciate it. And look at that. My picture is covering my words. How classy. All right, what intervention does this patient need? I think I already talked about it, but he needs fluid, he needs Tylenol. And I think, guys, you know, we ordered this blood culture, and it's not gonna come back for 3 days. Do I really wanna wait for 3 days for this blood culture to come back? No, there's no time. He could get really bad. His blood culture, or rather his blood pressure is already absolutely terrible. So what am I gonna do for him? I'm gonna give him some general broad spectrum antibiotics to cover a lot of different bugs that I think might be causing what's going on, but I really don't know, right? I mean, this is a tough picture. Unless you've reviewed these slides, I would be impressed, unless you're an infectious disease doc, if you could determine what this patient has based on what we've seen so far. Unless you're Dr. Fowler and you're very smart, and maybe you could tell us, but I'm just kidding, no pressure. Next slide, please. All right, so he was admitted to the patient to the pediatric floors. Here's a picture of some cute babies in white t-shirts. One of them is holding some sort of I guess a drumstick. I think another one's holding an apple. So that's fun. Next slide, please. Oh, what happened to my other slides? Are they there? Let's see, did we miss them? Go back one. Interesting. Maybe I skipped them. So this kid grew salmonella in their blood. Okay. Salmonella is a very interesting bug. Ever heard of typhoid Mary? Anyone? Ever heard of that story? Salmonella really causes kind of two areas of disease. One is a diarrheal illness, and one is an enteric fever that can spread to your bloodstream, and you can have a sort of a bacteremia, we call it, kind of a sepsis, kind of a bacteria in your blood. So this kid grew Salmonella typhi. It took 5-6 days. We had no idea what was going on. This kid kept having fevers. We kept touching his antibiotics, asking the infectious disease doctors what to do. And ultimately, they actually predicted it was this. Very smart infectious disease team in our hospital. Very proud to work with them. So basically, you can get salmonella from certain foods, from contaminated water, right? A lot of countries, unfortunately, don't have access to clean water, so that's something to keep in mind. And sometimes in interaction with certain animals, right? Fecal-oral route, sometimes fecal-oral ingestion. Anytime you touch something that might have a little bit of fecal matter on it, might have that bacteria, and let's say you wiped your mouth later because you had an itch, now you got Salmonella typhi, right? It gets into your blood. You can get it from different ways, okay? Now, it's actually more common, getting a fever from Salmonella typhi is more common in children and young adults than it is older patients, interestingly. So seeing in this patient was kind of epidemiologically appropriate or understood, okay? So humans are the only reservoir for Salmonella typhi, which is interesting. Approximately 200 to 300 cases are reported in the United States each year. Now keep in mind, 200 to 300, that's like half the size of this chat, right? There's 600, now there's 500. Some people became uninterested and left. But there were 600, and half of them in the whole country only would have gotten Salmonella. The other half of you, I don't know. I wish you guys the best. I hope you guys don't get Salmonella. What are some risk factors, okay? We talked about them already. Things, if you have certain diseases already, like sickle cell disease can put you at risk for it, okay? Going to certain countries, being exposed to certain conditions, like we said. Sometimes you can be a chronic salmonella carrier. So what does that mean? Ever heard of typhoid Mary? She had Salmonella typhi in her body for months and months, I think years, years. And she was basically told to leave. So I think she was a maid of some sorts. And she was told to leave where she was because she was sick. So she said, okay, I'll just get a new job. So they took blood cultures and they grew this. But meanwhile, she had already been to another job where she was a maid, I believe. I think it's a maid. And infected that whole house. And then all those people infected more people, and those people infected more people, and she jumped to multiple houses and infected so many people. And there was really no control on her, and no, I believe from what I read, no law in place to say, listen, you can't be doing this. We need to isolate you, right? Now we have patient isolations like I was talking about, right? So this person was spreading disease, and I think ultimately she didn't have bad intentions. I think she just wanted a job and she needed to make money. So who can blame her? But she gave a lot of people salmonella, okay? And sometimes you can get diarrhea with this strain of it too. So a lot of people got diarrhea. Thanks a lot, Mary. I really appreciate it. All right, so what else is going on here? They're modal gram-negative bacilli. Wow, those are some big words, Reagan. I don't even know what that means. What did I just say? So they're red. They stain red on a gram stain, which is a type of dye that you put on bacteria to take a look at them, and that can kind of guide you as to what kind of bug they are. And they're bacilli, meaning they're kind of rod-shaped. So some of them are cocci-shaped. They're circular. Some of them are rod shaped. Some of them have other weird shapes, especially if you're a parasite or you're a fungi, right? There's different ways to describe and look at things. And of course, there are nerds in the laboratory who do that for us, incredibly smart individuals doing work that I could never do, that studied for a very long time to be able to read and interpret these microscopic findings and tell us upstairs what to give the patient so that we can treat them, revive them, and send them home so they can potentially not give anyone else salmonella, but live happily. Unless it's COVID, then they're stuck at home, and hopefully they get the vaccine and everything works out. I'm rambling. Here we go. So it's a febrile illness. It can last 5 to 21 days. This guy had it for 20 days. It can really last longer. I mean, this is what Up to Date says. Up to Date's a really fun resource that physicians use to quickly get clinical data and recommendations for treatment. You need low inocula to get longer incubation times. What does that mean? The more bacteria you consume, if you get a nice big piece of poop and put it in your mouth with salmonella, you'll probably get the salmonella really quickly. You'll start getting the symptoms rather. If I just got a little bit, a few, it might take longer for that bacteria to replicate and grow and create symptoms in your body for you to say, okay, there's something wrong, right? There's something wrong. I need to go see a doctor, okay? Interestingly enough, this kiddo, because they were on amoxicillin for so long, we think that their fever curve was, or rather their condition was slightly treated. Maybe the amoxicillin was treating his bacteremia a little bit. So that's why he was getting better, getting a little worse, didn't feel the need to come in. So there's a lot of factors that you have to deal with as a doctor that are not just medicine, it's really detective work. You really have to be a good detective. And there's different stages of the illness. You can get fevers, it can progress to abdominal pain, and it can eventually result sometimes in really severe cases in a perforation, a sepsis. You can die. You might need your gut taken out. You might need surgery. It can get very severe. So when you have a fever, don't panic, okay? Wait it out. It's probably a virus. But if you have it for 20 days, that's probably a time you should have gone to the doctor about 10 days ago. Okay.
So Jeremy, this kid had a very high D-dimer and his INR clotting factor was somewhat out. Was he having DIC, disseminated intravascular coagulation?
So that's a wonderful question. I saw that brought up in the chat as well. So D-dimer is a really interesting enzyme, as I was saying. D-dimer is a way, it just kind of tells us if there's inflammation, and it can be sensitive to pick up if there's a clotting malfunction. So in this kid, was there a degree of DIC? Maybe, but if you remember back to his CBC, so DIC is really determined by a number of things: low platelets, low blood counts, and elevated coagulation factors. Okay, he did have some of those, and elevated coagulation times. And if I'm forgetting something, let me know. I think those are the big ones. So he had some of those. He had elevated coagulation times. He had elevated clotting factors, and he also had, or enzymes, and he also had low blood counts. So could this have been a small degree of DIC? Yes, but we asked ourselves, is this something that we clinically need to do, right? What's the treatment for DIC? The treatment for DIC is really determining, kind of going next level. What's causing the DIC? That's what you have to treat. The DIC itself, sometimes you need to replace blood and give blood. Sometimes you need to give clotting factors. Sometimes you need to give fluid if there's a sepsis, they have low blood pressure, they're not perfusing their tissues well. So this kid, could he have had a proportion or a small degree of DIC or a subclinical or subsymptomatic DIC, right? He had no bleeding, right? If you have a clotting issues, you might have bleeding. He didn't really have anything that we needed to treat actively. A hemoglobin of 11 wasn't something that we were too concerned about. But yes, Dr. Fowler, to answer your question, and I saw a number of very smart individuals write DIC earlier, but I wasn't responding because I had to make the case interesting. Yes, he probably did. I think it's reasonable based on clinical criteria. He did have a form of DIC. Here's something interesting. So this is very faint, and this is probably because this picture is from the 1980s, it almost looks like. This was before iPhones. He's got small little red dot-like lesions around his body. They can also be on the abdomen, is a very common place. That can be a sign of having Salmonella typhi. That can be, sometimes there's these very interesting textbook findings that you'll read in medical school and biology and anatomy class. You'll see these little findings, and a lot of times you don't see it. This kid didn't give us a nice, clear picture. He made us work for our money. And ultimately, he didn't have this picture, but thankfully, finally, his blood cultures grew and we had an answer.
Those are the rose spots, right?
Exactly. Those are the classic rose spots found in Salmonella typhi.
Jeremy, there's a study help in medical school. I wonder if you used it, called Sketchy Medical. Did you use that when you were in training?
My God. I swear by Sketchy. I refer to it still. Is that concerning? Maybe a little, but I love it. I think it's such an amazing resource. Why do you ask?
Well, because there is a Sketchy, you may recall, that trots out two birds to compare Salmonella enteritidis and Salmonella typhi. And the Salmonella typhi is the seagull. And the seagull is wearing an apron, and the apron has rose spots on it.
Yes, it does. I'm so excited that you just brought that. I love Sketchy. Thank you for bringing that up.
Well, and so the students that are listening, the 500 that are still here, will be seeing this as learning aids that will help them in school.
Yes, please check out Sketchy. There's also a really cool website that has a free trial that works in a similar realm of learning called Picmonic, which is also kind of works with these mnemonic pictures that can help you learn diseases. So it goes beyond infections, bacteriology, virology, and treatment of those organisms, and it goes even beyond that into certain medications, and they're both great. There's a lot of resources. I hear that nowadays people are using, oh my God, I'm forgetting the name of it right now. It'll come to me soon, but people love it now. Of course, I'm gonna leave you in suspense and not remember what it is, I guess. Salmonella typhi lab findings. So did we have leukopenia, meaning low white count? Nope, he was normal. He's confusing us. Did we have leukocytosis? No, we didn't have a high white count. Did we have transaminitis? Yes. What is transaminitis? Anyone know? I'll leave it in the chat so you guys can sound smart. What's transaminitis? Anyone know? No clue. Yeah, liver. Yeah, right. A liver enzyme elevation secondary to some sort of injury to the liver, right? And elevated inflammatory markers, he did have. CRP and procalcitonin are the two big ones us docs use now. COVID was a big one for using LDH, ferritin, and albumin is another one. We call it actually kind of a negative inflammatory marker in some respects. All right, so how do we diagnose a bug? How do we diagnose any bacterial infection, unless it's something that we feel pretty clinically strong about that we don't need a culture for? A culture, all right? Do we take cultures from the stools? Do we take it from the blood? Do we need to go into the marrow? Is it a marrow infection? Is it an infection of the bone? Do we need to take a tissue of the bone to see if there's some sort of osteomyelitis? Where is this infection? Let's find it and figure out what it is, because you and I could work together and think about what it is all day, but ultimately the only thing that's going to tell us what it is that piece of tissue. You can also do these cool newer rapid antibody tests. One of them is called a Weidel test. It's not very evidence-based. It doesn't help much. Ultimately, at the end of the day, with any bacterial infection, cultures. That's going to be on one of your test questions somewhere, sometime in your life. So you can think of me and thank me, and hopefully it helps. Next question, or next slide, please. All right, so something that came up, this is kind of a more new research thing. In the Middle East, South Asia, there's been increases in, and this is why, you know, Dr. Fowler was mentioning earlier how important it is for you to read up-to-date articles and new research articles that come out, because the world of medicine is literally constantly changing and you need to stay on top of it or you're gonna fall behind really quickly. In the Middle East, there's a Salmonella typhi that came out that's circulating, that's multi-drug resistant. And this is happening because in parts of lower income areas, sometimes they have access to only weird antibiotics. So if you have infections, they're kind of throwing it around and these bugs get exposed to it and they grow and they learn to fight it and they become multi-drug resistant. So in this area, we had a Salmonella typhi outbreak that was resistant to fluoroquinolones. It was also resistant to Bactrim. These are different types of antibiotics that work with different mechanisms. Like Dr. Fowler was saying, you can check out Sketchy Medical, Picmonic to learn how these antibiotics work. There's also great videos on YouTube. Search Google Images. Use whatever resources fits you all the best, okay? So what we have to do, we only didn't have to culture it. We had to call our friends down in the lab and say, listen, thank you. You know, you gave us a culture, but what is it sensitive to? Because this guy just got back from the Middle East and there's this huge outbreak. We don't know if we can just treat it like we do normally with a fluoroquinolone or with Bactrim. How do we treat it? So they said, okay, give us a sec. So they go down and they put it on different plates, different areas of the plate, and they expose each its own colony to a different antibiotic, and they see which ones survived and which ones didn't. The ones that survived to a certain antibiotic are the ones that are resistant to it, meaning it's not going to work on them. So you have to do ones that killed that little pocket of bacteria. And they told us that in this kiddo, ceftriaxone was okay. So our shot was right on the money. We sent him on ceftriaxone and actually later found out that there was some susceptibility to Bactrim. Bactrim is an oral antibiotic. So we didn't need to send them home with an IV line where he had to give himself injections every day. We could send them home with the normal pills, just like you get for strep throat, just like you get for urinary tract infection. He went a la casa. He's doing better. He was seen in the infectious disease clinic, happy as a clam and moody as a teenager, but no longer with Salmonella typhi and not being a typhoid Mary, passing off the bug to anybody else, especially in our very transmissible COVID times. I think that's my last slide. Did I have anything more? Oh, I have a nice thank you and a beautiful picture of Zeus, the American bulldog, 100-pound, gorgeous, brown cow, spotted mouthed beast of
Love the socks, by the way.
Yeah, thank you. Shout out to my mom, Hillary, for grabbing those socks for him to protect his little feetsies in the snow. So
Jeremy, what a wonderful talk. You up for a couple, three more questions?
I'm up for as many questions as people want to answer. I also, before I forget, you guys mentioned my Instagram earlier. I love it when you guys reach out to me on Instagram. If you have any questions, that's my primary area of contact regarding anything you want. I don't do it for money. I do it for fun, and I do it because I never had someone to tell me how to get to where I got, and I want to be there for you guys. So please reach out to me. I have a funny name. It's called Jeremy Grossman is cool. It's all one word, and you can ask any questions. And of course, I'll stay for as many questions right now as well.
Well, wonderful. Reagan, let's have two or three. What do you think?
Sounds good. Sorry, I'm sharing his Instagram on our Instagram right now. So I'll put that away for now. Okay, so let's see. Okay, how long did it take you to find your rhythm in your residency?
Wow. I mean, I think you're always finding your rhythm, but to a point where I got up out of bed and I didn't cry myself awake, probably took a good 6 months. I think 6 months hit and I said, I think I know what I'm doing. I think I like what I'm doing. And I think I'm going to make it in time for lunch. So again, it's different for different people. I think one of my mistakes in medical school was I focused primarily on learning every detail about everything theory-wise. And I didn't really spend a lot of time, as much time learning clinical medicine. So I struggled in my first year a lot, working with patients and learning how the hospital system works. It's so important. And I think it's probably more important as a fourth year medical student that you learn how that hospital system works so that you can function as a basic intern and thrive. I didn't thrive. I'm doing okay now though, don't worry. So 6 months is the time. And I hope that it takes all of you a lot less than that.
How often do you see infectious disease in your hospital or just in your residency?
You live and breathe it. The hospital is a cesspool of infections. I would imagine the ER is probably more of a cesspool than any other floor in the hospital for infections. It's important to always keep these isolations. It's important to do strict hand washing. We're wearing masks now. We're sanitizing areas. We're wearing eye goggles for protection. We're making sure our patients are prophylactically, right? We're preparing their bodies for any infection that might come with antibiotics if they have structural abnormalities or conditions that put them at risk for getting infections. All of these things, infections, you live and breathe it. And whether you want to be an infectious disease doctor in medicine, you're going to be one to a certain degree because it's such a huge part of medicine.
In our emails, we kind of did a little bio for you, and we talked about how you wish to practice medicine in impoverished and underserved communities. And so somebody wanted to know, would you consider pursuing an MPH for this, or like how are you planning on going about doing that?
It is something I've thought about, and I think in terms of how it depends on how you want to make an impact on the community that you want to make an impact on. Getting more letters after your name is not so much important as what you're going to be doing with those letters. What I want to do is I want to be on the ground with my patients, treating them, working alongside of them and holding their hand, being there for them through their difficult time and helping them through it, helping them get out of it. With an NPH, I'm sure that would give me a really good education that I could certainly apply to my medical day-to-day life, especially like similar to the ones that I have now in the hospital. But in my view, an NPH would be something I would want to do if I'd want to go more into the public health kind of overlooking administrative government, large body sector that's not going to really be patient to patient. So for me, right now, it's not something that I'd like to pursue. A few of my colleagues have NPHs. A few of them have MBAs. A few of them have PhDs, PsyDs, whatever, you name it. They have all of these careers that they've led before or dual degrees that they've had that I'm 100% sure play a huge impact in what they do. I know that one of my getting one of my degrees in psychology was because I couldn't choose between the two, between biology and psychology, and I was stressed about it. And it wasn't because I wanted 2 degrees; it was really because I couldn't figure out what I wanted. And I thought maybe at the time I wanted to be a therapist, so I kept that option open. Thanks to advice from my grandpa. Reach out to your family members. Just basic human life advice is important. You don't need to get all this advice from a doctor. You can get this advice from family members and people who have lived their lives, okay? So that being said, my therapy degree, or rather my psychology degree, has played a huge part in patient care. And I think I understand a little bit better than maybe some of my peers of how the human mind works and different ways on how to train a patient how to think with their new condition, how to deal with their new condition, and how to thrive with their new condition.
Gotcha. And I'm just going to ask 2 more questions. So
No limit, ask away.
what were your expectations of being a doctor, and how did those expectations measure up when you finally became one?
I think my expectations were Scrubs, if you guys have seen that show. Having fun, being a doctor. I'm a doctor. Yes, I'm here to help you. Haha, yes. Helping people, having the prestige, but it all really, it's such a small part of what you do. Yeah, human to human interactions is a huge part of what you do, but all of that nonsense that you see in the shows is really, the drama is not a part of what you're doing. And I think I wanted it to be to a certain degree because I had built so much on that. And of course I went to medical school and I learned the knowledge, and I finally got that MD degree, and I was like, okay, I'm going to live that doctor life I saw on Scrubs, and I'm going to apply my knowledge that I learned. But, day in and day out, there's a lot of repetition. There's a lot of nuances in each of the rotations. There's a lot of everything. And ultimately, at the end of the day, what you realize is what really matters is patient care, is you making sure that your patients are safe and making sure that they're getting proper treatment. And at the end of the day, that's got to be your first and primary and really your only concern. All of that other stuff you got to throw out the window. The doctors that are revered and loved by everyone that worked around them are the most humble people, the most intelligent people, a lot of them coming from nothing, that not only make an impact on their patients, but they make an impact on their peers and make a positive day-to-day experience in interactions with everyone around them. They exude positivity. They love what they do, and they remember to smile and laugh at the day. And that's what you have to remember. It's that being a doctor, this whole talk, there's a lot I'm kind of rambling on here, but being a doctor is a lot more than the shows and what you think it is for those of you who aren't physicians now. And getting exposure to what that life is, a glimpse into that life, will put you at such an advantage to your peers. And getting that clinical exposure, and I would say this is very clinical exposure, because we've gone through a case, we're talking about day-to-day life, and we're imagining what's going on in a day. We're not seeing it with our eyes, but we're hearing it and experiencing it, is so important. Okay, I'm done rambling.
Okay, last question. So it has been expressed that you look forward to multi-generational treatment of the family as a unit. Can you explain what you mean by that?
I mean, in one word, Medpeds. I love everything about medicine. I want to do everything in medicine. And I want to practice the best care. And you have to remember, when you're dealing with patients, it's not just their disease, it's the person and it's their family, right? Especially in pediatrics, we were talking about, you're not just dealing with the patient, you're dealing with their family, and how that family perceives their condition is going to be play a large role in how that child's care is going to be is going to proceed and it's going to take place. And you want to make sure that you're all on the same page, taking care of the family as a unit, especially when you're an outpatient physician and you're seeing the whole family. Dad might have new diabetes, mom might be obese and have a terrible diet, who's making the child eat poorly. They're going to develop diabetes. They're going to develop some form of other comorbidities later down the road. That's going to show the sister that it's okay to eat poorly. She's also going to develop other bad habits because she sees the sister developing other bad habits. That's going to lay on to the parents, and it's just going to be a mush pot of bad. You have to treat the whole family as a unit, and that's why it's so important. I love Medpeds, why I love family medicine. And why I love doing what I do on a daily basis and working with humans, not diseases, humans.
That was beautiful. Thank you so much for that answer. All right, well, I think that was it, everybody. Dr. Grossman, thank you so much for being with us tonight. Your presentation was fantastic. And we are so lucky that you joined us.
Jeremy, that was wonderful. Jeremy, there'll be some 5,000 virtual shadowing students that will see your presentation. Each one of them will become a medical professional and see probably 100,000 patients during a long career. So 5,000 times 100,000 is 500 million. Jeremy Grossman, you've touched 500 million lives tonight with this wonderful, heartfelt humanitarian presentation of yours, and just bless you for what you're doing. You're doing one of the hardest jobs there is, and let's everybody put a thank you one more time into chat for Dr. Grossman's wonderful presentation. Let's see it. Jeremy, look down at chat. I want you to see all these kids that are so very, very appreciative of what you've done for us tonight. So thank you and bless you. And folks, we're going to be here on Thursday. An important presentation is going to be on Thursday. Dr. Nesbitt, who is one of our leaders on the admissions committee process at UT Southwestern, will be with us. And I think you don't want to miss this. 7 o'clock, right, Reagan, on this coming Thursday?
Yeah.
And so we really look forward to having all of you. Reagan, any closing comments?
Yes, I would like to talk about the quiz. So quiz 42 will look very different, everybody. We're using a new quiz software called Firebox. So great news, there's no PIN or password anymore, so it's going to be super easy to access. I also put up a tutorial on our YouTube channel. It's 2 minutes long, so that's how easy it is to access. You can take it on your laptop, you can take it on your phone. Once you pass, just fill out your name and email and hit certificate to download it. And so the next slide is a QR code. And if you scan that with your phone, it will take you directly to the quiz. We will also post a link to the quiz on our website, in our email, and we'll probably link it on our Instagram as well. And if you have any issues, this is brand new for us too. So just email us and we will figure it out with you. And I think that's it.
Well, thank you everybody for coming. Jeremy, thank you again for a wonderful presentation.
Thank you so much. Thank you for having me, and good luck to you all, and bless you all for what you're doing as well.
Yeah, bless you back. Well, anyway, folks, this brings it to a conclusion. We hope to see you all on this coming Thursday, just two days away. Come and join us for a great talk. And on behalf of the whole virtual shadowing team and Dr. Grossman and Dr. Morchetti, and where is he? Where's the dog?
He's here. He's here.
And on Zeus, who is taking notes. Excellent. Don't wake up, Zeus. We want to thank you all for coming. So, Jeremy, good night. Thank you all for coming. Have a good evening.